Okay, buckle up. We are diving into something really important, something that affects so many lives, especially as men get older. Prostate health. Our source material today is, well, it's a deep, comprehensive look at this topic from a significant medical text, specifically Chapter 87, Benign and Malignant Diseases of the Prostate.
Yeah, and what's truly eye-opening here is just the sheer prevalence of these conditions. This isn't some niche health issue.
Right.
Changes in the prostate are a near universal experience for older men. Understanding the distinctions, the potential impacts, the clinical approaches, it's crucial, not just for medical professionals, but really for anyone trying to navigate health in later life.
Absolutely. And that's exactly our mission in this deep dive, tailored just for you. Think of this as your shortcut to getting profoundly informed.
Right.
We're going to take this dense material, break it down, find those golden nuggets of knowledge, and help you grasp the most important aspects of both the non-cancerous and the cancerous changes in the prostate. We want you to walk away with a level of understanding that feels sharp, insightful, like you really know what's going on. Kind of like understanding it like the elite professionals do, but without needing a medical degree to follow along. It's about cutting through the complexity, not just listing facts, but understanding the why and the so what.
And the source material provides a fantastic roadmap for that.
Yeah.
It starts with that foundational understanding of just how common these changes are as the prostate ages.
Right. So kicking off with that first big idea, the landscape of prostate health as we get older. It's generally known, I think, that prostate issues pop up more frequently with age.
Yeah.
But the numbers from the source, they're frankly staggering.
They really are. They provide a stark picture. From autopsy studies of men in their 8th decade, so their 70s.
Okay.
In this age group, over 90% of men show hyperplastic changes. That's the underlying basis for benign prostatic hyperplasia, or BPH.
The non-cancerous enlargement we hear about.
Exactly. And even more striking, over 70% show evidence of malignant changes, cancer at autopsy.
Whoa. Let me just pause on that for a second. Over 70% of men in their 70s having malignant changes found when they die, regardless of the cause. That feels incredibly high.
It does, doesn't it?
Yeah.
And that statistic is perhaps the single most important piece of information to grasp right up front.
Why is that?
Because it immediately tells you something critical.
Yeah.
Finding prostate cancer, especially in an older man, is incredibly common. The implication is profound.
Okay.
In an elderly population where other health issues, what the source calls competing causes of morbidity and mortality, are also very prevalent.
Right. Other things going on.
Exactly. You cannot simply find a prostate change and assume it's the most important or, the life-threatening issue.
Okay, so finding it doesn't automatically mean it's the problem that will cause harm.
Precisely. And this leads directly to a core principle highlighted in the source, one that guides modern prostate health management. The absolute necessity of a risk-adapted approach to diagnosis and treatment.
Risk-adapted?
It's not a search-and-destroy mission for every single cell that looks abnormal.
Okay, risk-adapted. So how do doctors figure out the risk then?
Well, this is where the source introduces a really helpful conceptual model, viewing prostate conditions as a series of states.
A series of states, like stages.
Sort of, yeah. Think of these states as distinct clinical milestones that a patient might be in. And the recommended therapy isn't static. It changes depending on the current state.
What defines a state?
Things like whether cancer has been diagnosed, how extensive it is, their symptoms, and crucially, the patient's overall health and likely lifespan. So the decision for treatment at any point is based on the extent of the disease, the symptoms it's causing now, the risk of it causing symptoms in the future, or, vitally, the risk of the patient dying from this disease compared to the risk of dying from something else within a relevant time frame.
That framework makes so much sense. It puts the prostate issue into the context of the person's entire health and life.
Yes.
It's not just about the cancer cells, it's about the impact on the individual.
Precisely. And the decision-making balance shifts depending on whether you're dealing with a benign condition like BPH or malignant cancer.
Okay.
For BPH, it's primarily about managing symptoms, the difficulty urinating, urgency, frequency, and preventing potential complications like urinary retention or infections.
Right.
You weigh the impact of these symptoms against the potential side effects or complications of medical treatments or surgery.
So for BPH, it's about comfort and preventing immediate problems, balancing that against potential downsides of pills or procedures.
That's right. Now, with cancer, the stakes can be higher, But the principle of balancing is similar, really. You're balancing the probability that the cancer is clinically significant, meaning it's aggressive enough to actually cause symptoms or lead to death from the cancer, against the potential harms or morbidities of the treatments themselves, and considering the patient's existing health issues, those comorbidities.
So finding cancer isn't the end of the decision. It's the beginning of a complex assessment. Is this cancer likely to hurt this person? And is the treatment needed to address it going to cause more harm than the cancer itself might?
That's the core challenge. That high autopsy prevalence figure is the foundation of that thinking. Many prostate cancers, especially the small, low-grade ones found in older men, may never progress.
Right.
The challenge, and you could say the art, is identifying the aggressive ones that need intervention and leaving the indolent ones alone, managing that balance to maximize lifespan and quality of life.
So the key insight right up front is prostate changes, including cancer, are incredibly common with age, and because of that, simply finding them isn't enough.
Mm-hmm.
You need a smart, risk-adapted strategy based on the individual's specific situation and the likelihood of the disease causing harm to them. That framework is what guides everything that follows.
It truly does. And to understand the conditions, well, we need to understand the structure where it all begins.
Okay, yeah. Before we dive deeper into the diseases, let's get our bearings on the organ itself. Anatomy and pathology. What is the prostate and where is it located?
Okay, think of the prostate as a small gland, roughly the size of a walnut in a young man, nestled deep within the male pelvis.
Okay.
It's located just below the bladder. And the tube that carries urine from the bladder out of the body, the urethra, actually runs right through the middle of it.
So it's wrapped around the urinary tube. That explains why prostate problems often affect urination.
Exactly. And its neighbors are really important to consider, especially when we talk about treatment. Behind it is the rectum, which is why a physical exam can sometimes feel part of the prostate.
Right, the DRE.
Yeah. Above it is the bladder. And surrounding it are complexes of veins and, crucially, the neurovascular bundles. These bundles contain the nerves responsible for achieving erections, and they run along the sides of the prostate.
Okay, important nerves.
Very important. And just below is the urinary sphincter, a muscular valve that helps control urine flow passively. Understanding these neighbors is vital because surgery or radiation targeting the prostate can affect these structures, impacting urinary control or sexual function.
Got it. So location matters because treatments can have unintended consequences on its neighbors. Yeah. What's it made of inside? Inside,
the prostate is a mix of glandular tissue where fluids are produced and muscle and fibrous tissue called stroma.
Okay.
Glands arranged in lobules surrounded by that fibromuscular stroma. If you look closer, microscopically, the functional units called acinar units have two main parts. The epithelial cells, which form the lining of the glands and produce the prostate's fluids.
Right.
And the stromal cells, which are the fibroblasts and smooth muscle cells surrounding the glands.
And some key substances come from those cells. I think I know one.
Yes. Prostate-specific antigen, or PSA, is one of the most well-known. It's a protein produced primarily by the epithelial cells. Prostatic acid phosphatase, or PAP, is another. And both the epithelial cells and the stromal cells respond to male hormones, or androgens, like testosterone. They have special receptors for these hormones, and their growth and function depend on them.
That hormonal link seems really important for understanding some treatments down the line.
It absolutely is. The main circulating male hormone, testosterone, produced mostly in the testes, is converted within the prostate gland itself into a more potent form called dihydrotestosterone, or DHT.
DHT, yeah, okay.
This conversion is driven by an enzyme called 5-reductase. This is a critical pathway because certain medications can block this enzyme or block the hormone receptors, influencing prostate growth or cancer growth.
Okay, location, neighbors, composition, hormonal influence. Does the prostate have different internal zones? And do different problems tend to show up in different zones?
Yes, it does. This zonal anatomy is really key to understanding where BPH and cancer typically arise. There's a central part, the periurethral portion, or transition zone, which directly surrounds the urethra as it passes through the gland.
Right, the tube.
Exactly. This zone tends to increase in size, especially after the age of 55, due to the non-cancerous growth of cells. This is the area where BPH typically develops.
Yeah.
And as it grows, it can squeeze that urethra, causing those urinary problems we talked about.
So BPH is like the core getting bigger and pressing on the pipe. That's a helpful way to think about it.
It is, for its effect on urination. In contrast, most prostate cancers develop in the peripheral zone, which is the outer part of the gland.
The outside edge.
Right. Because it's on the outside, this is the part of the prostate that can sometimes be felt during a digital rectal examination, or DRE. This peripheral location means a cancer might be palpable if it's large enough.
Okay, so BPH tends to be central and affect urine flow directly, while cancer is often peripheral and might be detectable by touch. You could think of the prostate maybe like a peach. The tit area in the middle is the transition zone, where BPH happens, and the fleshy part outside is the peripheral zone, where cancer often starts.
That's a very helpful analogy. Different problems, different locations within the fruit. It gives us a physical basis for understanding the different symptoms and how these conditions might be detected.
Right. With that anatomical foundation, let's shift gears to focus on prostate cancer itself, starting with the big picture numbers and the factors that influence risk. Epidemiology.
Okay. Looking at the statistics from the source, for the United States in 2021, there were estimated to be nearly 250,000 new cases of prostate cancer.
Wow.
And over 34,000 deaths attributed to the disease. The source does note that the number of deaths has decreased over the past decade.
That's good news.
It is, and this decrease is widely attributed to the impact of widespread PSA testing, which has allowed for earlier detection.
That sounds like a clear win. Testing leads to earlier diagnosis, which leads to fewer deaths. But then the source immediately introduces what you call the paradox.
Yes, and it is a fundamental tension in managing this disease. The paradox is this. While it's estimated that 1 in 8 men will be diagnosed with prostate cancer during his lifetime,
1 in 8.
Only about 1 man in 41 who is diagnosed will actually die from that cancer.
Wow. Okay. So being diagnosed is common, but dying from it is much, much less common relative to the diagnosis rate. That brings us right back to the idea that not all prostate cancers are aggressive or life-threatening.
Exactly. And this paradox is really at the heart of the controversy surrounding screening and potential overtreatment. Finding lots of cancers is one thing. Figuring out which ones are actually dangerous is the critical challenge.
So what makes someone more likely to be diagnosed with prostate cancer? Are there genetic factors involved?
Yes, genetics plays a significant role. Family history is a strong predictor. Having one first-degree relative, a father or brother with prostate cancer, increases your risk by about 2.5 times.
Okay.
If you have 2 or more first-degree relatives, that risk jumps to 5-fold.
5 times.
Yeah. The source estimates that a substantial proportion, maybe 40% of early onset cases, and 5 to 10% of all prostate cancers have a hereditary component.
And ethnic differences are noted too.
Yes, there's a clear difference. African-American males, when matched for age, have a higher incidence of prostate cancer.
Mm-hmm.
They also tend to be diagnosed at a more advanced stage and with higher grade, more aggressive cancers. Genetic studies have identified specific genetic variations that might contribute to these differences, including variants in genes related to vitamin D receptors and genes involved in testosterone metabolism.
So specific genetic quirks can influence both risk and how aggressive a cancer might be. What about very early changes at the cellular level? Anything mentioned there?
The source points to early molecular changes, like changes in the activity of certain genes involved in detoxifying harmful substances.
Okay.
Also, an interesting finding is that many cancers appear to develop near areas of inflammation in the prostate. That suggests that chronic inflammation might play a role in initiating or promoting cancer growth.
Inflammation as a potential driver. That's interesting. Beyond genetics and internal biology, what about outside influences like environment and diet?
This is another important piece of the puzzle. The source notes that while the frequency of finding prostate cancer at autopsy is similar globally,
Right, we talked about that high number.
The incidence of clinical disease, the cancers that are diagnosed and actually cause problems, varies widely around the world.
Huh.
This strongly suggests that environmental and dietary factors influence whether these potential cancers actually grow and become clinically significant. Factors like high consumption of certain dietary fats or compounds found in well-cooked red meats are linked to increased risk.
And the Western environment effect you mentioned.
It's observed that men of Asian descent who move to Western countries experience an increased risk of developing prostate cancer, similar to what's seen with breast cancer in Asian women moving to the West.
Wow.
This pattern reinforces the idea that something in the Western environment or lifestyle promotes the clinical manifestation of the disease.
Are there any protective factors mentioned, things people might do or eat?
Yes. The source lists several factors associated with lower risk or potentially slower progression. These often relate to diet and include compounds found in soy, like genistein, cruciferous vegetables like broccoli, sulforaphane, and tomatoes, lycopene.
Okay, lycopene in tomatoes, I've heard of that.
Right. Certain cholesterol-lowering drugs, like statins, are also mentioned as potentially protective. And lifestyle factors like avoiding smoking, exercising regularly, and maintaining a healthy body weight are linked to a potentially reduced risk of cancer progression.
So helping keep a slow-growing cancer from becoming aggressive.
Potentially, yes.
Here's where it gets really interesting. It's not just one simple cause. It's this complex interplay of inherited risk, your genetic background, your diet, your environment, potentially inflammation, and your lifestyle. That complexity is why managing it isn't straightforward at all.
Absolutely. And that complexity directly feeds back into the need for that risk-adapted approach we started with. You have to consider all these potential influences when assessing an individual situation.
Okay. Given this complex picture of risks and prevalence, how do doctors actually approach finding and managing prostate cancer? This brings us back to diagnosis and treatment guided by that clinical states model you mentioned.
Right. The source describes the journey of prostate cancer as a continuum. It might start with preneoplastic changes, develop into a localized cancer confined to the prostate, potentially spread to become metastatic disease, cause symptoms, and eventually impact mortality. This entire process can unfold over decades.
Decades. Wow. And the clinical states model helps navigate that long path.
Precisely. The model, often shown as a diagram in these texts, is designed explicitly to help healthcare providers and patients avoid overdiagnosis and overtreatment.
Right, the harm part.
Especially of cancers that aren't likely to cause harm. It organizes the disease process into discrete, definable states.
How are these states defined, operationally?
Well, operationally, they're defined by whether a cancer diagnosis has been made or not. If cancer is diagnosed, the state depends on factors like whether the primary tumor has been treated, if there's evidence of spread metastases on imaging, and the patient's hormone levels, specifically testosterone.
Okay.
And the source emphasizes that a patient is only considered to be in one state at any given time and moves to the next state only upon documented progression.
And treatment decisions are tied to the specific state.
Yes. Within each state, the decision of if and how to treat is based on whether the patient is experiencing symptoms directly related to the cancer.
Okay.
If not, the decision hinges on the estimated risk that the cancer poses to their quality or length of life, weighed against the risks of the potential treatments, and the likelihood that the patient might die from something else before the cancer becomes a problem.
Right, those competing risks again.
Exactly. Generally, more advanced disease states imply a greater need for intervention, but the specific intervention depends heavily on the state.
Okay, so if someone hasn't been diagnosed yet, how is the decision made about even looking for cancer? Screening, basically.
For individuals without a known diagnosis, the decision to test for prostate cancer, typically starting with a PSA blood test, is based on two main factors: their estimated life expectancy and the likelihood that a clinically significant aggressive cancer might be present.
So it's not automatic for everyone?
No. Testing is less likely to be beneficial for someone with a very short life expectancy from other health issues, as even an aggressive prostate cancer might not impact them in their remaining time.
And once there is a diagnosis, how does the model apply?
The model for diagnosed patients explicitly factors in the probability of the cancer causing symptoms or leading to death. The source gives an example. A patient whose localized tumor is successfully removed with surgery.
Okay.
As long as their PSA remains undetectable, they stay in that localized disease-treated state. The time they spend in that state becomes a measure of how effective the local treatment was, although determining whether it's a cure versus long-term control might take years.
That's a crucial distinction you mentioned. Cure versus control. What's the difference according to the source?
The source defines cure as the complete elimination of all cancer cells.
Right.
That's the ideal goal for most cancers.
Right.
Cancer control, on the other hand, is when the progression of the illness is slowed or altered by treatment such that it's unlikely to cause symptoms, metastasize, or shorten the patient's life expectancy within a relevant time frame.
And from a patient's perspective, how does that feel?
Well, importantly, the source notes that from the patient's point of view, both cure and effective cancer control can be therapeutically equivalent.
Okay.
If they prevent symptoms and avoid significant treatment side effects. Even if some cancer cells persist and cause a PSA rise after initial treatment, immediate intervention isn't always necessary. The decision to treat, again, depends on the tempo of the disease progression observed in that individual and the balance of risks and benefits of further intervention. And this raises an important question. How do you actually decide who needs aggressive treatment right away versus who might be better served by watchful waiting or, a less intensive approach. Not just a biological question, but a question of managing risk over a person's lifetime.
Exactly. And that brings us to the very beginning of that process. What happens before a diagnosis, focusing on prevention and early detection efforts.
Okay, on the prevention side, the source is quite straightforward. Currently, no agent is approved by the FDA specifically for the prevention of prostate cancer.
Really? None. But there's been research into preventing it, right? I recall hearing about drugs typically used for BPH, the non-cancerous enlargement.
Yes, exactly. A class of drugs called 5-reductase inhibitors, or 5-ARIs, the same drugs used to shrink and enlarge prostates in BPH, have been studied in large clinical trials specifically for prostate cancer prevention.
And what did they find?
These trials showed that they do reduce the future risk of being diagnosed with prostate cancer. The PCPT trial with finasteride and the REDDC trial with tucastride both demonstrated a reduction in incidence compared to a placebo.
So they prevent diagnosis. That sounds good.
Well, they reduce the likelihood that cancer will be detected. However, the concern highlighted is that these trials found that the majority of cancers that were prevented were low-risk, indolent cancers, precisely the kind we might not need to treat anyway.
Okay, so preventing the discovery of harmless cancers isn't necessarily a win.
That's the interpretation. Neither finasteride nor dutasteride is approved for prostate cancer prevention based on these results, largely due to that concern about preventing clinically insignificant disease. Trials looking at dietary supplements like selenium and vitamin E also found no benefit in reducing incidence.
So preventing the diagnosis isn't the same as preventing harm, especially if it's preventing low-risk cancers. Prevention seems complicated. What about early detection?
This is where the core challenge really surfaces. Early detection strategies aim to find cancer before it causes symptoms.
Right.
But given the high prevalence of harmless cancers we discussed earlier, the critical task is balancing the benefit of detecting clinically significant cancers, the aggressive ones that would cause harm or death if left untreated.
Okay, finding the bad ones.
Against the harm of overdiagnosis and overtreatment of the many clinically insignificant cancers that would never have impacted the patient.
That sounds like a really complex decision for a patient and doctor.
It absolutely requires a careful conversation, what's known as shared decision-making.
Right.
The decision of whether to even pursue diagnostic testing is based on factors like whether the patient has symptoms, if a physical exam, DRE, finds something abnormal, or if there's a change or elevation in the serum PSA level. Genetic risk factors are also considered in this initial assessment.
So prevention isn't simple. And even the decision to look for cancer with screening tools is complex because of the risk of finding things that might lead to unnecessary treatment and side effects.
That's the fundamental tension that the field grapples with. And the primary tool for early detection, besides the physical exam, is that PSA blood test.
Okay, let's take a closer look at those tools used for early detection, starting with the physical examination, the digital rectal examination, or DRE.
Right. The DRE involves a doctor feeling the prostate through the rectal wall. The goal is to assess its size, consistency, and feel for any hard or irregular areas that might suggest cancer. As we mentioned earlier, most cancers develop in the outer part of the prostate, the peripheral zone, which is the part accessible during a DRE. So if a cancer is in that location and large enough, it might be felt as a hard or nodular area.
How often does an abnormal DRE actually mean cancer?
According to the source, about 20 to 25% of men with an abnormal DRE are found to have prostate cancer on biopsy.
Okay, so not always, but a significant chance.
Yes, and it's worth noting that other things, like BPH or even small stones within the prostate, can sometimes feel firm too. The DRE is one piece of information, but it's not diagnostic on its own. And interestingly, the source notes that a DRE does not significantly affect PSA levels.
Okay, now the big one, PSA, prostate-specific antigen. There seems to be so much discussion and controversy around this test.
There is, and for good reason. PSA is a protein made by the prostate gland, specifically by both healthy and cancerous prostate cells. Its natural job is related to liquefying semen.
Okay.
The key thing to understand about PSA, as the source stresses, is that it is prostate-specific, meaning it comes almost exclusively from the prostate, but it is not prostate cancer specific.
Ah, that's the crucial point then. Elevated PSA doesn't automatically mean cancer?
Exactly. Levels can be elevated for reasons other than cancer, like BPH, inflammation, or even after ejaculation or manipulation of the prostate.
Got it.
In the bloodstream, PSA circulates in a couple of forms, mostly bound to other proteins, and a smaller amount is free or unbound. Understanding the ratio of free to total PSA has been explored to help distinguish between BPH and cancer, as cancer tends to produce more of the bound form.
Okay.
And if the prostate is completely removed, say by surgery, PSA levels in the blood should drop to undetectable levels within about 6 weeks because the source of the protein is gone.
When did PSA testing become so central to early detection?
Well, PSA testing for early detection became widespread after FDA approval back in 1994.
Okay.
This led to a dramatic shift. Now, a large majority, over 70 to 80% of newly diagnosed prostate cancers are found when they are still considered clinically organ confined, meaning they appear limited to the prostate.
That's a huge change.
It is. A significant change from when most cancers were detected at a more advanced stage.
Does a higher PSA level indicate a higher risk of aggressive cancer?
Generally, yes. The level of PSA in the blood is associated with the risk of having prostate cancer and to some extent the outcome. The source notes, for example, that a single PSA measurement at age 60 is strongly associated with the lifetime risk of death from prostate cancer. And most deaths from prostate cancer occur in men whose PSA levels over time have been higher, say, in the top quartile, above 2 in DML.
But back to that paradox we keep mentioning.
Right, because many men with elevated PSA levels do not develop lethal cancer.
No.
This is the core of the ongoing debate and controversy regarding routine PSA screening.
Right.
While some large studies have suggested that widespread screening can lead to a reduction in deaths from prostate cancer, the debate continues because of the significant risk of finding and treating cancers that wouldn't have caused harm anyway, that problem of overdiagnosis and overtreatment.
And that's led to different recommendations from major health organizations.
Exactly. The source highlights the differing guidelines. The U.S. Preventive Services Task Force, USPSTF, a major independent panel, initially recommended against routine screening for all men, citing that the harms outweigh the benefits.
Wow, against it completely.
Initially, yes, a grade D recommendation back in 2012. They later softened this slightly in 2017, recommending shared decision-making, that crucial conversation with your doctor about the pros and cons for men aged 55 to 69.
Okay.
But they still recommended against routine screening for men 70 and older. They did acknowledge that the increasing use of active surveillance for low-risk cancers has helped mitigate some of the harms of screening.
And the American Urological Association, the AUA, what's their stance?
The AUA also recommends shared decision-making for men between 55 and 69. They found moderate evidence of benefit in this age group, but felt evidence was lacking for others, while the risks of overdiagnosis and overtreatment remain for all.
So, pretty similar recommendation then.
Yes, so they also advise against routine screening outside that 55-69 age range unless there are specific individual circumstances.
It sounds like the consensus is basically talk to your doctor in that specific age range and maybe not screen older men routinely. The source also proposes some practical guidelines to improve the impact of PSA testing.
Yes, the chapter suggests 3 common sense rules that could potentially have a greater real-world impact than rigid age guidelines alone.
Okay, what are they?
First, avoid testing men who have little to gain. This means men with a very short life expectancy, like most asymptomatic men over 75, unless they have unusual circumstances, like maybe a very high baseline PSA or excellent overall health.
Okay.
It also suggests that men with very low PSA levels, say below 1 NGML, might be tested less frequently.
So, be smart about who you test and how often. What's the second rule?
Second, do not treat those who do not need treatment. This directly addresses overdiagnosis.
Right.
They point out that many cancers found by screening are low risk and can be effectively managed by active surveillance, avoiding immediate treatment side effects.
Makes sense. And the third rule?
Third, refer men who do need treatment to high-volume centers with experienced teams.
Why is that?
The argument is that outcomes, both in terms of cancer control and managing side effects, are generally better when treatment is performed by specialists who do these procedures frequently.
Okay.
The overall aim of screening, they argue, should be to maximize the benefit of finding aggressive cancers while minimizing the harms of dealing with indolent ones.
Those 3 rules seem very focused on improving the process of screening and treatment, not just the test itself. What about using a specific PSA number as a trigger for a biopsy, like the famous 4.0 cutoff?
Yeah, historically, a common cutoff for recommending a biopsy was a total PSA of 4 nanograms per milliliter, NGML, or higher. However, the source notes that if you biopsy every man with a PSA above 4, most of them will not have cancer.
Most? Wow.
Yes, and conversely, studies show that many men with PSA levels below 4 do harbor cancer cells in their prostate. Data from major trials like the PCPT confirm that there's no PSA level below which the risk of finding cancer is 0.
So it's not a perfect threshold at all.
No. The PSA level helps establish the likelihood of finding cancer if a biopsy is performed, but it's not a definite yes or no. The goal now is to make PSA testing more effective at finding the significant, potentially harmful cancers in younger men while reducing the detection of those low-risk cancers in older men that are unlikely to cause problems.
Got it.
And the source adds a practical point. If a man with an elevated PSA has symptoms of a prostate infection, bacterial prostatitis, he should be treated with antibiotics before a biopsy, as infection can falsely elevate PSA.
Okay.
However, they specifically caution against just giving routine antibiotics to asymptomatic men who only have an elevated PSA.
Okay, so the standard PSA test is useful but has significant limitations and ongoing controversy. Are there newer tests to help doctors decide if a biopsy is needed after an elevated PSA to refine that risk?
Yes, this is where second-line screening tests come in. Their purpose is precisely that, to provide more refined risk information after an initial elevated PSA to help guide the decision about whether to proceed with a biopsy.
How do they work?
Instead of just the total PSA number, these tests look at different forms of PSA or other related proteins or even genetic markers in urine. One example mentioned is the 4K score test.
Okay.
It measures 4 specific prostate proteins, kallikreins, and combines them with clinical information in a calculation and algorithm to estimate the % risk of finding aggressive prostate cancer on a biopsy.
Ah, focusing on aggressive cancer, not just any cancer.
Exactly, which aligns with that goal of identifying clinically significant disease. It can also predict the likelihood of developing aggressive cancer over the next 20 years.
Interesting. Any others?
Another test is the Prostate Health Index, or PHI. That's a blood test combining total PSA, free PSA, and a specific form of free PSA called negative prop PSA. This combination has been shown to be a better predictor of prostate cancer than total PSA or free PSA alone.
Okay.
And there are also urine-based tests mentioned, like tests measuring PCA3 mRNA levels or exosomes, which are tiny particles shed by cells found in urine. Examples are the SelectMBx or ExitX prostate tests.
These newer tests sound like they are trying to add layers of precision to that initial PSA signal. It's a prime example of how complex even seemingly simple health checks can be. It's definitely not just a simple yes or no answer with PSA alone.
It's all about refining the estimation of risk to make the most informed decision about the next step, which is typically a biopsy if the risk seems high enough.
Okay. If those screening tools and risk assessments suggest there might be a significant cancer, what's the definitive next step to confirm it?
That's the biopsy and pathology stage. The source is clear. A prostate biopsy is the only way to definitively confirm the diagnosis of prostate cancer. It involves taking small tissue samples from the prostate using a needle.
How is the biopsy guided to make sure they get the right spot?
The biopsy needle is guided by imaging, commonly transrectal ultrasound, TRUS. More recently, MRI is also used, sometimes fusing MRI images with real-time ultrasound during the procedure.
Fusion biopsy.
Exactly. That helps target specific suspicious areas seen on the MRI, in addition to systematically sampling different regions of the prostate, mainly the peripheral zone. The standard practice often involves taking multiple samples, perhaps 12 or more cores.
Can a biopsy miss cancer?
Yes, it's possible because the needles are just sampling a relatively large gland that might have cancer in only certain areas. It's a sampling error issue.
Okay.
The source notes that men with an elevated PSA but an initial negative biopsy might need further evaluation, potentially using those advanced risk tests we just discussed, or an MRI, or even a repeat biopsy if the suspicion for clinically significant cancer remains high.
Right.
And again, that practical note, if a patient has symptoms of bacterial prostatitis, they should be treated with antibiotics before a biopsy, as inflammation can complicate things.
Once the tissue samples are taken, what happens in the pathology lab? How do they analyze them?
The pathologist examines each tiny tissue core under a microscope. They look for cancer cells, and if present, they assess how much the core is involved, like the length or percentage.
And what type of cancer is it usually?
Over 95% of prostate cancers are adenocarcinomas, meaning they arise from the glandular tissue. Other types are rare. It's also rare for cancers from other organs to spread to the prostate, though nearby cancers like colon or bladder can sometimes invade it directly.
And this is where they determine how aggressive the cancer looks, using the Gleason system.
Exactly. The Gleason grading system has been the standard for assessing the aggressiveness of prostate cancer, based on its microscopic appearance how the glandular patterns look compared to normal prostate tissue.
How does it work?
Pathologists assign a grade from 1 to 5 based on the most prevalent pattern they see, and another grade from 1 to 5 for the second most prevalent pattern. Grade 1 looks very much like normal prostate tissue, while grade 5 looks highly disorganized and undifferentiated. These two grades are added together to get a total Gleason score, historically ranging from 2 to 10. The source notes that the area with the most poorly differentiated pattern, even if it's a small area, is considered important because it often reflects the cancer's potential behavior. They also look for things like whether cancer is seen invading nerves, perineural invasion, or extending outside the prostate capsule.
This Gleason system, I've heard it causes a lot of confusion for patients.
It absolutely does, and the source addresses this directly. Over time, pathologists essentially stopped using the lowest grades, 2 through 5. So the lowest total score typically given now is a 6, 3 plus 3.
Okay.
But since the scale technically goes up to 10, a Gleason 6 sounds like it's right in the middle. Patients often hear 6 out of 10 and think it's moderately aggressive, which can cause significant fear and maybe push them towards treatment they don't need.
But a 6 isn't really middle-of-the-road risk.
No, in modern pathology, a Gleason score of 6 is actually considered a favorable risk cancer, often low grade.
That disconnect between the number and the perceived risk sounds like a real problem for communication.
It is. To address this, a new, simpler system called the grade group system has been developed and is now widely used, often alongside the Gleason score.
How does that work?
It groups Gleason scores that have similar prognosis into 5 distinct categories. Grade group 1 is Gleason 6 or less. Grade group 2 is Gleason 3 plus 4 equals 7. Grade group 3 is Gleason 4 plus 3 equals 7. Note the order matters here. A primary pattern of 4 is worse than a primary pattern of 3. Grade group 4 is Gleason 8. Grade group 5 is Gleason 9 or 10.
Okay, so grade group 1 corresponds to that Gleason 6, clearly signaling it as the lowest risk group. This new system seems much more intuitive for understanding risk.
That's precisely the benefit. It simplifies communication, accurately classifies the lowest risk cancers into grade group 1, and has been shown to correlate better with actual prognosis than the old numerical Gleason score alone.
This grading system change is a perfect example of how medicine evolves to communicate risk more clearly to patients. It's not just academic. It really affects how people feel about their diagnosis.
Absolutely. It's about clarity and appropriate risk perception.
Okay. Once cancer is diagnosed and graded, how do doctors figure out how far it has spread? That's the staging process, right?
Exactly. Staging uses the TNM system, which stands for tumor, node, and metastasis. It's a standardized way to describe the extent of the cancer.
Okay, TNM. Can you quickly break down those T categories for the primary tumor? What do they mean?
Sure. The T categories range from T1 to T4. T1 is a tumor that is clinically inapparent. You can't feel it on DRE or see it on standard imaging.
Okay.
It's usually found incidentally during surgery for BPH, that's T1A or T1B, or, most commonly nowadays, found only because of an elevated PSA leading to biopsy. That's T1C, representing over 70-80% of new diagnoses.
Wow, most are T1C then. What's T2?
T2 tumors are confined within the prostate gland, but are palpable on DRE or visible on imaging, but still within the capsule.
Okay, still inside.
Right. T3 means the tumor extends through the prostate capsule, maybe into the tissue just outside, or into the seminal vesicles nearby. And T4 means it has invaded adjacent structures like the rectum, bladder wall, or pelvic wall.
And N1 means spread to regional lymph nodes, and M1 means distant spread, like to bones or other organs.
Correct. The source explicitly notes that the DRE alone is not accurate for determining how far the cancer has spread within or beyond the prostate, or whether lymph nodes are involved.
Right, we knew it wasn't perfect.
Exactly. Because of this limitation, imaging was incorporated into the staging system.
But even imaging isn't perfect for staging prostate cancer, is it?
No, the source highlights that as a limitation. Currently, no single imaging test definitively tells you with certainty the full extent of the disease, including whether it's strictly confined to the organ, if seminal vesicles are involved, or if there's lymph node spread, especially microscopic spread.
So what imaging is used?
Different techniques provide different pieces of information. Transrectal ultrasound, TRUS, is mainly used to guide biopsies, not really for accurate staging. Standard CT scans aren't very sensitive for detecting spread just outside the prostate or to lymph nodes. MRI is generally better, especially for assessing the local extent of the tumor and helping plan treatment like surgery or radiation.
What about spread to bones?
For distant spread to bones, a radionuclide bone scan, scintigraphy, is traditionally used. But it detects the bone's reaction to cancer, not the cancer directly, and can have false positives from other bone issues like arthritis or healing fractures.
Okay.
Crucially, the source notes that bone scans are rarely positive if the PSA is below 10 ngml, unless it's a very high-grade tumor.
So figuring out the exact stage is challenging even with imaging. How does stage relate to prognosis? Does it give a general idea?
Oh, yes. The stage of diagnosis is highly correlated with prognosis. The source provides survival rates based on overall stage grouping. If the cancer is localized, T1 or T2 at diagnosis, the 5-year survival rate is essentially 100%.
Okay, very good for localized.
If it's regional, T3 or T4 without distant spread, the 5-year survival rate is also reported as 100%.
Still very good.
But if there's distant metastatic disease at diagnosis, M1, the 5-year survival drops significantly, down to about 30%.
Those are dramatic differences.
They are. But despite this, the source strongly emphasizes that stage alone is often insufficient to accurately predict an individual's outcome and guide treatment, especially for the very common T1C cancers detected only by PSA.
Why is that?
Because other factors, particularly the Gleason grade or grade group, are crucial. There's a wide range of prognosis even within a single T stage. Some T3 tumors might be curable with local treatment, while some T1 cancers, despite being small, might be very high grade and have a high risk of spread, potentially needing additional systemic therapy right away.
This is a lot to keep track of. It's clear that simply finding out how far the cancer has spread is harder and less definitive than you might think based just on the T and M categories.
It's definitely more nuanced. And precisely because stage alone isn't enough, additional tools have been developed to try and refine that risk assessment.
Okay. If stage alone isn't enough to get a precise handle on a patient's likely outcome, what other tools do doctors use to refine that prediction? This is where you mentioned prognostic models and nomograms come in.
Yes. These are sophisticated tools, basically statistical models, developed precisely to provide a more personalized prediction of a patient's likely course. They combine multiple pieces of readily available information.
What kind of information do they combine?
They typically take factors like the initial clinical T stage, the biopsy Gleason score or grade group, the number of biopsy cores that contain cancer, and the baseline PSA level. Some use simple cutoffs. Others use these factors as continuous variables. They use mathematical models to crunch these numbers together.
And what do these models predict? What's the output?
The source says they can predict several important things. 1, the probability that a clinically significant cancer is actually present in the gland. 2, the likely extent of the disease, like whether it's confined to the prostate or has spread to lymph nodes. And importantly, 3, they can predict the probability of success for specific local treatments based on these pre-treatment factors.
It sounds like there are probably a lot of different nomograms out there.
There are. The source mentions over 100 have been reported. And there can be debate within the field about what exact probability threshold constitutes high risk based on the predicted success or failure rate from a nomogram.
Right.
The source points out that while these tools are valuable for informing decisions, they don't give a definitive cutoff that automatically tells a doctor or patient exactly what to do. Clinical judgment and shared decision-making based on the patient's values and preferences are still essential.
So they are powerful tools to inform the conversation about risk, but not meant to replace it.
Exactly. And these models are constantly being updated and refined to include more factors, like new biological information from the tumor, and even adjusting for improvements in treatment techniques over time. It makes the decision process very dynamic. And if we connect this back to the bigger picture, these nomograms and models are really essential attempts to bring more precision to clinical decision-making, especially given that standard staging alone isn't always precise enough to predict outcome, particularly for those very common low-stage cancers.
That makes a lot of sense. Okay, so once we have a diagnosis, a grade, a stage, and maybe a refined sense of risk from nomograms, what are the actual treatment options for cancer that's still considered clinically localized, confined to the prostate?
Right. For clinically localized prostate cancer, meaning it hasn't clearly spread beyond the prostate or perhaps immediate surrounding tissues, the main management options discussed are radical prostatectomy, which is surgical removal of the entire prostate.
Okay, surgery.
Radiation therapy, using either external beams or implanted radioactive sources, which is brachytherapy. Or active surveillance, which is essentially close monitoring without immediate treatment.
Surgery, radiation, or active watching. how do doctors and patients choose among these? It seems like a really big decision.
It is a big decision. The choice is influenced by several factors. Whether the cancer is causing any symptoms, the estimated probability that the untreated cancer will negatively impact the patient's quality or duration of life, and whether the cancer is likely to be cured by just local treatment versus possibly needing a combination of local and systemic whole-body therapy from the start.
It sounds difficult to compare surgery and radiation directly. Are there good head-to-head trials?
It is difficult, and the source acknowledges this. It knows there's no definitive, clear evidence that one local therapy is superior to another in terms of long-term cancer outcomes, like overall survival.
Why not?
Well, partly due to the slow nature of the disease. It takes many, many years to see differences in survival. Also, it's hard to conduct perfect comparative trials without bias in who gets referred where, differences in physician experience, and different ways of measuring success in trials.
So how do they compare them?
A common way researchers compare treatments is by looking at PSA outcomes after treatment, like PSA relapse-free survival. How long does the PSA stay low?
How is PSA used to monitor success after treatment? You said it's different after surgery versus radiation, right?
Yes, it's defined differently because surgery removes the prostate while radiation leaves it in place.
Okay.
After radical prostatectomy, where all the prostate tissue should be gone, PSA should become undetectable in the blood, typically below 0.1 or 0.2 ngml within about 6 weeks. If PSA remains detectable or starts to rise later, it indicates that some cancer was left behind or has recurred.
Got it. Undetectable after surgery is the goal. What about radiation?
After radiation therapy, however, the remaining normal prostate tissue continues to produce PSA, so PSA levels don't drop to zero. Biochemical failure, or recurrence based on PSA after radiation, is usually defined by the Phoenix definition. A rise in PSA by 2 ngml or more above the lowest point it reached after treatment. That lowest point is called the nadir.
Okay, a rise of 2 above the lowest point. And for active surveillance?
For patients on active surveillance, simply a rising PSA isn't necessarily defined as failure, as levels can fluctuate naturally or rise slowly without therapy being immediately needed. It's usually looked at in context with other factors.
So PSA is a monitoring tool, but you absolutely have to know which treatment was received to interpret it correctly. What about other important outcomes besides just the PSA number?
Well, other important outcomes include whether the cancer visibly progresses locally or spreads elsewhere, that's objective progression, cancer-specific survival, dying from prostate cancer, and overall survival, dying from any cause. However, as mentioned, it can take many years to see differences in these outcomes after initial treatment for localized disease.
Okay.
The source also reinforces that the extent of local disease within the prostate impacts prognosis. More extensive local disease means a higher chance of spread to lymph nodes, even if not seen on scans, and a lower chance of being cured by local treatment alone. Even within T1 or T2, there's a range.
Let's talk about radical prostatectomy, the surgery, in more detail.
Okay. Radical prostatectomy aims to completely remove the prostate gland, and often the attached seminal vesicles. The surgical goals go beyond just removing the cancer. They also include preserving urinary continence by protecting the external sphincter muscle and, ideally, preserving erectile function by carefully avoiding damage to those neurovascular bundles that run alongside the prostate.
Who is surgery typically recommended for?
It's generally advised for patients who are expected to live at least another 10 years.
Why 10 years?
Because the potential long-term benefits of surgery in preventing cancer progression take time to potentially outweigh the immediate risks and impacts on quality of life. Surgery can be done through an open incision, retropubic or perineal, or using minimally invasive techniques, most commonly now with robotic assistance.
Is one surgical approach clearly better for cancer control or side effects like incontinence or ED?
The source notes that while minimally invasive approaches like robotic surgery often lead to shorter hospital stays and less blood loss compared to traditional open surgery, the rates of cancer control, recovery of urinary continence, and recovery of erectile function are generally comparable across different surgical techniques when performed by experienced surgeons. A key takeaway highlighted is that the outcomes seem strongly dependent on the individual surgeon's skill and experience, perhaps more so than the specific method used.
That's interesting. Skill over specific tool. What about giving hormone therapy before surgery? Does that help?
Giving hormone therapy, androgen deprivation therapy or ADT, before surgery called neoadjuvant therapy has been studied, especially for higher-risk cancers. While trials showed it can shrink the prostate size and potentially reduce the likelihood of cancer being found right at the edge of the removed tissue, positive margins.
Which sounds good.
These benefits haven't consistently translated into better long-term outcomes, like PSA relapse-free survival after surgery, so it's not a standard approach for most patients.
Okay. And the big side effects, incontinence and erectile dysfunction, what affects recovery?
These are significant potential side effects, yes. Factors increasing the risk of urinary incontinence after surgery include older age and certain aspects of the patient's anatomy around the urethra. Surgeon skill is also a factor in minimizing damage and preserving sphincter function.
And erections?
Recovery of erectile function is more likely in younger men, those who had good function before surgery, and critically, depends on whether the neurovascular bundles can be completely preserved during the operation. If nerves are spared, recovery, if it occurs, often starts months after surgery. If nerves must be cut on one or both sides to remove the cancer, potency is significantly reduced.
But there are treatments for ED.
Yes, the source notes that various treatments like pills, sildenafil Viagra, tadalafil Cialis, urethral inserts, or injections allow many men to recover satisfactory sexual function even if natural erections don't fully return.
Okay, that's surgery. What about radiation therapy? How is that delivered?
Radiation therapy uses high-energy radiation to kill cancer cells. It can be delivered from outside the body, external beam radiation therapy or EBRT, or by placing tiny radioactive sources directly into the prostate gland, brachytherapy.
How has external beam radiation changed over the years? I hear it's more precise now.
It is, much more so. Modern external beam radiation, using techniques like intensity-modulated radiation therapy, IMRT, is highly precise. It allows doctors to sculpt the radiation dose, delivering a higher, more conformal dose directly to the prostate while significantly minimizing exposure to surrounding healthy tissues like the rectum and bladder compared to older 3D conformal techniques.
And that allows for higher doses.
Exactly. This precision has enabled the safe delivery of higher, more effective radiation doses, often over 80 gray units, which leads to better local cancer control and generally fewer side effects than historical lower doses.
Dose matters for killing the cancer.
Yes. Delivering a sufficiently high dose is critical for maximizing the chance of eradicating cancer in the prostate. Studies have shown that higher doses lead to better cancer control outcomes.
What about shortening the treatment course? I've heard about that too.
Right, that's hypofractionated treatments. It means giving a higher dose per treatment session, but over fewer sessions. This can significantly reduce the total number of treatments and shorten the overall treatment time, sometimes from 8 to 9 weeks down to 4 to 5 weeks, or even fewer in some protocols. Recent studies suggest these shorter courses offer good cancer control rates with no apparent major increase in morbidity compared to longer courses.
Is external beam radiation sometimes combined with hormone therapy, the ADT?
Yes, and this has been a very significant development, particularly for intermediate and high-risk cancers. Multiple large clinical trials have shown that combining external beam radiation with androgen deprivation therapy improves outcomes.
How so?
For patients with unfavorable intermediate risk cancer, adding a short course of ADT, around 4 to 6 months, to radiation significantly improves overall survival. For high-risk disease, longer courses of ADT, typically 18 to 36 months, combined with radiation, are considered standard of care and have proven superior to shorter courses or radiation alone.
You mentioned patient-reported outcomes earlier from a big trial comparing surgery, radiation, and watching. What did that show about side effects?
Yes, the PROTECT trial provided valuable insight into the patient's experience with active monitoring, radical prostatectomy, and radical radiotherapy, which included hormone therapy for men with mostly low and intermediate risk cancer.
What were the key differences?
Radical prostatectomy had the greatest negative impact on sexual function and urinary continence, and these effects tended to persist over time compared to the other groups, despite some recovery.
Okay, surgery hit those areas hardest. What about radiation?
Radiotherapy initially affected sexual function, worse at 6 months, then some recovery, and caused more bowel irritation. Also worse at 6 months, some recovery, but maybe more persistent issues like bleeding later. It had less effect on urinary continence, but did cause more urinary irritation, like frequency and urgency initially, which mostly recovered.
And active monitoring.
In the active monitoring group, sexual and urinary function gradually declined over time, which might be expected with aging anyway.
But overall well-being.
Notably, despite these differences in specific side effects, there weren't significant differences among the three groups in measures of anxiety, depression, or overall quality of life related to cancer or general health.
So the treatments have different impacts on specific functions, urinary, bowel, sexual, but maybe not as much difference in overall mental well-being or general quality of life, at least in that trial population. What about brachytherapy, using the implanted seeds?
Brachytherapy involves implanting small radioactive seeds directly into the prostate. The principle here is that the radiation dose is very high right close to the seeds, but falls off rapidly, with distance the inverse square law.
So, intense dose right where you want it.
Exactly. This allows for a very high dose concentrated in the prostate, while limiting exposure to the nearby bladder and rectum, maybe even more so than external beam in some ways.
How is it done? Is it complex?
It's typically an outpatient procedure. Using ultrasound imaging and sophisticated computer planning, tiny radioactive seeds are precisely placed throughout the prostate based on a customized map designed to deliver the radiation dose evenly and effectively to the gland. It's done under anesthesia, usually transperineally.
Are the outcomes good? Does it work well?
With modern techniques, outcomes are quite good in terms of local control, particularly for favorable risk disease. Studies report high rates of PSA relapse-free survival, often comparable to other treatments for appropriate patients. Post-treatment biopsies often show no remaining cancer.
And side effects for brachytherapy?
It's generally well tolerated, but common side effects include increased urinary frequency and urgency, which can sometimes persist for several months as the radiation effect settles. Patients who've had prior surgery for BPH, like a 2RP, or who have significant obstructive symptoms at the start, may have a higher risk of urinary retention or persistent voiding issues after brachytherapy. Rectal irritation, proctitis, is reported less frequently now, maybe less than 2%.
Okay, so that covers surgery and radiation. The third option for localized disease isn't really a treatment, it's active surveillance. Tell us more about that.
Correct. Active surveillance means carefully watching the cancer over time, instead of treating it immediately. This approach has gained significant favor as we've better understood that paradox of common but often slow-growing cancers. It's a direct effort to reduce overtreatment and its associated side effects.
Who is active surveillance actually for? It can't be for everyone.
No, absolutely not. It's specifically recommended for patients with cancers that are considered to be of low aggressiveness, cancers that experts believe can be safely monitored without immediate intervention based on specific criteria.
How is the monitoring done? What does active mean?
Patients on active surveillance are monitored closely at regular intervals. This typically involves digital rectal exams, PSA blood tests, sometimes periodic prostate MRI scans, and importantly, repeat prostate biopsies. But crucially, the repeat biopsies are usually done as indicated, meaning if there are specific changes in the DRE, PSA trend, or imaging that suggest the cancer might be becoming more aggressive and potentially warrants curative treatment.
So it's not just passive watch and wait. It's active monitoring with the intent to intervene if needed.
Exactly. That's a key distinction.
And how are patients selected for this? What are the criteria?
Selecting the right candidates is critical and is an area of intense ongoing study and refinement. Generally accepted criteria often include clinical stage T1C, cancer not felt or seen on standard imaging, a low Gleason score, grade group 1, Gleason 6, involvement in only a small number of biopsy cores, for G3 or fewer, with only a small percentage of cancer within each involved core, for example, less than 50%, and often a low PSA density, which is the PSA level divided by the prostate volume.
So it's really for those small volume, low-grade cancers where the risk of progression is thought to be very low based on multiple factors.
Exactly. The source notes that predictive tools, like nomograms specifically designed for active surveillance eligibility, are being refined to better identify patients who are truly safe candidates. As these tools improve, hopefully more patients who don't need immediate treatment can confidently choose active surveillance and avoid the side effects of surgery or radiation. That brings us to a specific clinical state: rising PSA after definitive local therapy. This is when a patient has had surgery and/or radiation intended to cure their cancer, but their PSA level begins to increase again, and standard imaging like CT or bone scans doesn't show any obvious disease elsewhere in the body.
So the rising PSA is the only sign of trouble, at least initially.
Yes, often that's the sole manifestation. The big question the doctor and patient face is, does this rising PSA mean there's still cancer left behind at the original site in the prostate area, local recurrence? Or does it mean the cancer has already spread systemically but is just too small to see on traditional scans, micrometastases, or potentially both?
And why is that distinction so important?
It's critical because if it's just local recurrence, it might still be potentially curable with additional local treatment, often called salvage therapy. If it's already systemic, then local treatment alone is unlikely to be curative, and systemic therapy might be needed eventually.
How is the decision made about giving additional local treatment, like salvage radiation after surgery?
After radical prostatectomy, if the PSA starts to rise, the decision about whether to give salvage radiation therapy to the area where the prostate used to be, the prostate bed, is often guided by several factors. These include findings from the original surgical tissue, like whether cancer was found at the edge, positive surgical margin, how quickly the PSA starts rising after surgery, and the PSA level at the time the decision about salvage therapy is being made.
You mentioned standard imaging isn't very good at finding where the PSA is coming from when the PSA level is low. Are newer scans changing that picture?
Yes, this is a big area of progress and change right now. Newer types of PT scans that use specific tracers that directly bind to prostate cancer cells, like PSMA-P scans using tracers targeting prostate-specific membrane antigen, or fluciclovine P scans, are much more sensitive than traditional scans.
More sensitive.
Yes. They can often detect small amounts of recurrent or metastatic cancer in the prostate bed, lymph nodes, or even distant sites at much lower PSA levels than traditional scans could. These newer scans are becoming increasingly important tools to help figure out if the rising PSA is coming from a local spot that can be treated with salvage therapy, or if it seems to be more widespread, guiding the next treatment decisions. The source notes that the ability of these scans to find cancer correlates with the absolute PSA level. The higher the PSA, the more likely the scan is to be positive, but they can find disease at quite low levels sometimes.
That makes sense. More cancer cells, more tracer uptake. What factors suggest that salvage radiation after surgery is more likely to work to be successful?
Factors that predict a better response to salvage radiation include having had positive surgical margins in the removed prostate specimen, a lower Gleason score in the original cancer, a long time interval between the surgery and the PSA starting to rise, a slow PSA doubling time, meaning the PSA is rising slowly, and perhaps most importantly, a very low PSA level, often less than 0.5 ngml, maybe even lower, at the time the salvage radiation is actually given. Starting earlier seems better.
What about if the PSA rises after initial radiation therapy? Can salvage local therapy be done then?
It's generally considered more complex and less common than salvage radiation after surgery. Salvage local therapy, like salvage radical prostatectomy, salvage cryotherapy, freezing, or maybe even salvage re-radiation or high-intensity focused ultrasound can be considered after primary radiation failure if a biopsy confirms persistent cancer in the prostate and sophisticated imaging doesn't show definite spread elsewhere. However, the source notes that selecting the right patients for this is challenging. Patient selection in published series is often poorly defined, and the potential risks and side effects, morbidities of these salvage treatments after prior radiation can be significant.
Okay. So a rising PSA doesn't always mean the cancer is back locally where it started. It could mean it's already spread systemically, just invisibly.
Correct. A rising PSA can certainly indicate that there are subclinical or micrometastases cancer cells that have spread but are too small to be detected on current scans, potentially with or without local recurrence happening at the same time. In these cases, the decision to start systemic treatment often depends on the estimated likelihood that the patient will develop visible metastatic disease in the future and in what time frame.
Does a rising PSA always require immediate treatment with systemic therapy, like hormone therapy?
Not necessarily, especially if it's rising slowly. The source points to data, particularly from series following men after surgery, suggesting that in some cases, if the PSA is rising but no disease is visible on scans, patients can be safely monitored for a period. One series showed that for men with a rising PSA after prostatectomy who received no systemic therapy until metastases were documented, the median time for metastases to appear was 8 years.
8 years? Wow.
Yes, and 63% remained metastasis-free at 5 years. This indicates that a rising PSA doesn't always signify immediate danger requiring full-body treatment right away. The tempo matters.
How do doctors predict who is more likely to progress quickly when their PSA is rising like that?
The risk of progression is associated with several factors: the Gleason score of the original cancer, the time interval from initial treatment to PSA recurrence, and especially the PSA doubling time, how quickly the PSA level is rising. A rapid PSA doubling time, for example, the source mentions examples like 10 months or less, and especially 3 months or less, is strongly linked to a higher risk of developing metastases sooner and poorer survival. Most physicians, according to the source, would advise considering treatment when PSA doubling times are 12 months or less. However, predicting risk accurately in this state remains challenging, and the data are complex, partly because many patients receive some form of therapy before metastases actually appear, making it hard to study the pure natural history. Predictive models are continually being refined, and this raises an important question, especially now. With these new highly sensitive imaging techniques like PSMA PET becoming more available, do we need to rethink the timeline for intervening when PSA starts to rise? Finding tiny spots of spread earlier is possible, but does treating them earlier always translate to better long-term outcomes? The balance between catching spread early and potentially over-treating someone whose cancer might have progressed very slowly anyway is a key area of investigation.
That's a fascinating tension, especially with better imaging. Okay, what about cancer that has spread visibly beyond the prostate and regional lymph nodes? Metastatic disease.
Right. That takes us to the state of metastatic disease. The first category discussed is non-castrate metastatic prostate cancer. This applies to men whose cancer has spread to distant sites visible on imaging like bones, lymph nodes outside the pelvis, or other organs either when they are first diagnosed or after previous local treatment has failed, and their blood testosterone levels are still in the normal or non-castrate range, generally defined as above 150 ng/dL in the source, though sometimes lower cutoffs are used.
What kind of symptoms do men with metastatic disease typically experience?
The most common symptom is pain, usually from cancer spread to the bones, osseous metastases. However, the source importantly notes that many men can have extensive metastatic disease visible on scans without experiencing any symptoms at all initially.
Really? Widespread but no symptoms?
Yes. Less common but potentially serious symptoms can arise from cancer heavily infiltrating the bone marrow, causing anemia or low platelets called myelophysis, problems with blood clotting, coagulopathy, or, critically, cancer pressing on the spinal cord compression, which is a medical emergency requiring urgent treatment to prevent permanent paralysis or loss of function.
How is this stage of disease, non-castrate metastatic, typically treated? What's the standard approach?
The cornerstone and standard treatment for decades for non-castrate metastatic prostate cancer has been to dramatically reduce or eliminate the influence of male hormones, primarily testosterone, on the cancer cells throughout the body. This is achieved through androgen deprivation therapy, or ADT.
ADT, okay. How is that done?
ADT can be achieved surgically, which involves removal of the testes, bilateral orchiectomy. This provides rapid and permanent castration, but is less acceptable to many patients now. More commonly, it's done medically, using drugs. A less frequent approach mentioned is just blocking the androgen receptor with anti-androgen drugs, but that's usually less effective on its own.
Where do the male hormones actually come from, and how do the drugs work on that?
Over 90% of the main male hormone, testosterone, is produced by the testes. A smaller amount, less than 10%, is produced by the adrenal glands. Medical ADT primarily works by stopping the production of testosterone by the testes.
How do the drugs do that?
The most common medical therapies are injectable drugs called GnRH agonists, like leuprolide or goserelin, or GnRH antagonists, like daguerreolex or the newer oral drug releulex. These act on the pituitary gland in the brain to ultimately shut down the signal, telling the testes to make testosterone, resulting in chemical castration. Other drugs like abiraterone block enzymes like CYP17 involved in making androgens not just in the testes but also in the adrenal glands and even within the tumor cells themselves. The source includes a diagram showing these hormone pathways and where different drugs act.
You mentioned estrogens were used historically.
Yes. DES, diphenhydroestradiol, was one of the first effective treatments, but it's rarely used now due to a higher risk of serious vascular complications like blood clots, strokes, and fluid retention. The GnRH analogs were developed partly to avoid these risks while having similar anti-cancer potency.
You mentioned GnRH agonists can cause an initial surge, a flare.
Yes, that's an important point. GnRH agonists, like leuprolide, initially cause a temporary rise in testosterone levels for the first week or two before levels drop. This flare can potentially worsen symptoms like bone pain or, more dangerously, spinal cord compression if the cancer is near the spine. Because of this, they might be relatively contraindicated in men with significant baseline pain or risk of cord compression.
How do you avoid the flare?
Pure GnRH antagonists, like daguerreolex or releulex, work differently and achieve castrate levels rapidly without causing that initial testosterone flare. Sometimes an anti-androgen drug is given temporarily alongside a GnRH agonist for the first few weeks to block the effects of the flare.
What are the side effects of ADT? It sounds like lowering testosterone so drastically would have widespread effects.
It does, and the source details what's often called the androgen deprivation syndrome. The side effects are significant and can impact quality of life. Common ones include hot flashes, fatigue, weakness, loss of muscle mass, weight gain, especially abdominal fat, and anemia.
Okay.
There can also be effects on mood and cognition, including depression or changes in personality. Metabolic changes are also very common and concerning. Alterations in cholesterol levels, increased insulin resistance, and a higher risk of developing diabetes and cardiovascular disease over the long term.
And bone health.
Yes, a major concern is a significant decrease in bone mineral density over time, which greatly increases the risk of osteoporosis and fractures. The source stresses this risk is often underappreciated by both patients and providers, especially in men who might already have low bone density or other risk factors.
How is that bone loss managed?
Assessing fracture risk at the start of ADT is important, often using tools like the FRAX scale. Management includes recommending adequate calcium and vitamin D intake, weight-bearing exercise, and sometimes prescribing bone-strengthening medications like bisphosphonates, for example, zoledronic acid, or the RANK ligand inhibitor denosumab. Another agent, teremethine, is also mentioned for this purpose.
You mentioned antiandrogens block the hormone receptor. How are they used in this setting?
Older first-generation non-steroidal antiandrogens, like bicalutamide and lutamide, have largely been replaced by more potent next-generation agents, like enzalutamide, apalutamide, darolutamide. These newer agents are much more effective at blocking the androgen receptor signaling pathway.
Do they have different side effects than the drugs that lower testosterone?
Yes, because they don't necessarily lower serum androgen levels themselves, their side effect profile can be different. They might cause fewer hot flashes, have less impact on libido or muscle mass, cause fewer personality changes, and potentially less bone loss compared to traditional ADT. However, because testosterone can still be converted to estrogen, they can sometimes cause breast tenderness or enlargement, gynecomastia, which can limit long-term use, but might be preventable with tamoxifen or prophylactic breast irradiation.
Are these antiandrogens used alone for metastatic disease?
Generally, no, not for long-term control. Most trials suggest that cancer-specific outcomes are inferior when antiandrogens are used as the sole therapy compared to achieving castrate levels of testosterone with surgery or GnRH drugs. For example, even high-dose bicalutamide resulted in shorter time to progression and inferior survival compared to surgical castration in one large trial.
So, simple ADT lowering testosterone was the standard for many years. What changed the approach? Why add other drugs?
A major paradigm shift occurred when large clinical trials showed that adding other systemic agents to standard ADT right from the start for newly diagnosed, non-castrate metastatic disease significantly improved progression-free survival and, importantly, overall survival compared to ADT alone.
What was the first drug shown to do that?
The first systemic therapy shown to prolong life in the more advanced castration-resistant setting was docetaxel chemotherapy, approved back in 2004. Subsequently, trials like Charted and Stampede showed that adding docetaxel upfront to ADT for newly diagnosed metastatic disease improved survival, particularly for patients with more extensive high-volume disease, like 4 or more bone lesions or spread to organs.
And those newer hormone-like drugs were also added up front.
Yes, that was another huge step. Agents like abiraterone acetate, which blocks androgen synthesis, plus prednisone, and the next-generation AR antagonists like enzalutamide and apalutamide were all shown in large Phase 3 trials, like Latitude, Stampede, Enzamet, Arches, Titan, to significantly prolong life when added to standard ADT compared to ADT alone for newly diagnosed metastatic disease. These results fundamentally changed the standard of care, moving towards combination therapy, ADT plus one of these agents, for many, if not most, patients with metastatic hormone-sensitive prostate cancer.
What about giving ADT intermittently instead of continuously, taking breaks?
Intermittent androgen deprivation therapy, IADT, is an approach where hormone therapy is given for a period, for example 6 to 9 months, then stopped once the PSA is low, allowing testosterone levels to recover. Therapy is restarted when the PSA rises again to a certain threshold.
What's the rationale?
Primarily, it's to give patients a break from the side effects of continuous ADT, hopefully improving quality of life during the off-treatment periods. There's also a biological theory, though unproven, that allowing endogenous testosterone to rise might induce some differentiation in surviving cancer cells, potentially delaying the development of resistance.
Does it work as well as continuous ADT for cancer control?
That's the key question. The source notes that it's still uncertain whether IADT increases, decreases, or doesn't change the overall duration of sensitivity to hormone therapy, or has comparable long-term cancer control outcomes compared to continuous therapy, especially for men starting with lower PSA levels or less extensive disease. Large trials have suggested non-inferiority for overall survival in some settings, but perhaps not all. It's considered a safe approach in terms of immediate side effects, and some men prefer the break, but long-term impact on survival remains a topic of discussion. The trial mentioned it was ongoing.
How predictable are the outcomes of ADT generally, whether continuous or intermittent?
The initial anti-cancer effects of different ADT strategies that achieve castrate levels are broadly similar. The clinical course often follows a somewhat predictable pattern. An initial response with PSA decline and sometimes tumor shrinkage, then a period of stability where remaining cancer cells might be dormant, and then eventually, after a variable amount of time, months to many years, the cancer starts to grow again despite the low testosterone levels. This leads to a rising PSA and eventually regrowth visible on scans. This is the development of castration-resistant disease.
Why is an ADT usually curative?
Because castration-surviving or resistant cancer cells are often present right from the time of diagnosis, even if they are a small minority initially. ADT selects for these resistant cells over time.
What kind of response rates do you see initially?
The source mentions PSA normalizes in maybe 50-70% of men. Measurable disease regression is seen in about 50%, and bone scans might improve in about 25%, though the majority just show stabilization.
How long does the response last?
Survival duration is inversely proportional to the extent of disease at the start of ADT, and also strongly related to the PSA nadir, the lowest PSA level achieved, typically measured around 6 months after starting ADT. Patients whose PSA nadir remains above a certain threshold, for example, 4 ngml or even 0.2 ngml in some studies, have markedly inferior survival compared to those who achieve a very low nadir. This suggests considering alternative or additional therapies early for those poor responders.
So even with metastatic disease, there's still this unresolved question about the best timing, when to bring in these powerful systemic therapies.
Exactly. How early should they be offered? Should they be used as adjuvant therapy right after local treatment for high-risk disease? Should they start at the first sign of PSA recurrence after local therapy? Or should we wait until metastatic disease is visible on scans or symptoms develop?
Have trials looked at earlier therapy?
Yes, but the source notes that many trials looking at immediate versus delayed ADT for non-metastatic recurrence were largely underpowered to show a survival benefit, or were criticized for methodological issues. It mentions specific trials, like one showing benefit for radiation plus 3 years of ADT versus radiation alone for localized disease, but the control group outcome was poor, and another looking at ADT for positive lymph nodes after surgery, where survival curves overlapped initially. The optimal timing, especially for adding the newer potent agents in the non-metastatic setting, is still being actively investigated in ongoing trials.
It's amazing how much has changed in treating metastatic disease, moving beyond just simple hormone depletion to more targeted approaches and combinations. But figuring out the right time to step up treatment, especially before symptoms appear, is still a big question.
It truly is a rapidly evolving landscape, driven by both clinical trial results and a deeper understanding of the cancer's biology at different stages.
Okay, so hormone therapy works for a while, but for most men with metastatic disease, the cancer eventually figures out a way to grow even when testosterone levels are very low. What happens when the cancer becomes resistant to standard ADT?
That defines the state of castrate-resistant prostate cancer, or CRPC. This is diagnosed when there's evidence of disease progression, either rising PSA, new lesions on scans, or worsening symptoms despite the patient's blood testosterone levels being maintained at or below the castrate level, typically defined as 50 ngml or lower.
And this is typically the most challenging stage of the disease.
Yes, generally. CRPC is responsible for most of the serious complications associated with the prostate cancer and is ultimately lethal for most men who reach this stage.
How does CRPC usually manifest? What are the signs?
The most common manifestation is a rising PSA level, often accompanied by progression of existing bone metastases or development of new ones. Spread to lymph nodes or visceral organs like the liver or lungs is less frequent initially, but can certainly occur as the disease advances. Patients may or may not be experiencing symptoms when CRPC is first detected biochemically by PSA rise.
How is progression assessed in CRPC? It sounds like it might be difficult if it's mainly in the bones.
It can be. Because the disease often has this bone-dominant and PSA-dominant pattern, reliably assessing how well treatments are working can be challenging. Traditional bone scans show bone reaction, not tumor volume directly, and can be slow to change or hard to interpret. The source points out that while PSA response is often used as an endpoint in clinical trials, it hasn't been proven to be a perfect surrogate measure for actual clinical benefit or survival in this state. Favorable changes in either PSA or scans can support regulatory approvals for new drugs, but they don't always perfectly reflect how the patient is feeling or doing long-term.
So treatment decisions shouldn't just be based on making the PSA go down.
Absolutely not. The source stresses that the management objective in CRPC must be based on the specific disease manifestations in the individual patient. For example, if a patient has significant pain from bone disease, relieving that pain is a primary and highly clinically relevant goal, perhaps more important than just lowering the PSA number. The central focus remains on delaying or preventing disease progression, managing symptoms effectively, maintaining quality of life, and prolonging survival.
How has the treatment landscape for CRPC changed over the past decade or so? You mentioned docetaxel was the only option for a while.
It has changed dramatically. It's really night and day compared to before 2010. Up until then, docetaxel chemotherapy was essentially the only therapy approved by the FDA that was proven to prolong life in the CRPC setting. Since then, our understanding of the underlying biology of resistance has increased significantly, leading to the development and approval of multiple new effective therapies.
What was the key biological insight that drove this change, understanding why the cancer becomes resistant?
A critical insight was realizing that even when circulating testosterone levels are very low, castrate levels, the majority of CRPC cancers still express the androgen receptor, AR, and remain dependent on AR signaling for their growth and survival.
How do they do that without testosterone?
They develop various clever mechanisms to keep this pathway active. The source mentions several. The cancer cells can overexpress the AR, make many more copies of the receptor. They can develop mutations in the AR gene that make it more sensitive or active even with low hormone levels. They can produce AR splice variants, altered forms of the receptor that might lack the part that binds testosterone and are constitutively active. Or they can upregulate enzymes involved in androgen biosynthesis, allowing them to produce their own androgens within the tumor microenvironment. Up to 50% might harbor these oncogenic changes.
And these insights led directly to the development of new drugs that target these resistance mechanisms.
Exactly. The next generation anti-androgens, like enzalutamide, apalutamide, darolutamide, which potently block AR signaling, and the CYP17 inhibitor abiraterone, which blocks androgen synthesis, plus prednisone, are highly successful because they effectively target these adaptive changes that keep the AR pathway switched on. All of these agents have been proven in large trials to prolong life in CRPC, used either before or after chemotherapy, and are now standard treatment options.
What about looking beyond the androgen receptor, genetic testing, and more targeted therapies?
Yes, that's another major area of progress. Large-scale molecular profiling efforts of CRPC tumors have led to a more biologically based classification. One key finding was a higher-than-expected frequency, maybe 10-20% or more in some studies, of alterations, either inherited germline or acquired somatic, in genes involved in repairing DNA damage, particularly BRCA1, BRCA2, ATM, and others.
And can those be targeted?
Yes. Tumors with these specific DNA repair defects have been shown to be sensitive to a class of drugs called DRE inhibitors. Olaparib and rucaparib are now FDA approved for treating metastatic CRPC patients whose tumors have specific DNA repair gene mutations, often after progressing on prior therapies. Niraparib also has breakthrough designation.
Any other targeted therapies?
Immunotherapy with checkpoint inhibitors, specifically pembrolizumab, has been approved for patients whose tumors have high microsatellite instability, MSI-high, or mismatch repair deficiency, dMMR. This is found in only a small percentage of CRPC cases, maybe 2-3%, but for those patients, the response can be significant. Notably, this approval was based on efficacy across different MSI-high tumor types, not just prostate cancer.
Are there other types of therapies approved for CRPC that work differently?
Yes, the toolbox has expanded significantly beyond AR pathway drugs, PRP inhibitors, and immunotherapy. Other approved life-prolonging therapies mentioned include the cellular immunotherapy Sibutral-C, which aims to stimulate the patient's immune system against the cancer, the second-generation taxane chemotherapy cabazitaxel, often used after docetaxel, and radium-223, which is an alpha-emitting radioactive isotope that specifically targets bone metastases and has been shown to improve survival and reduce skeletal events in men with bone-predominant CRPC.
And anything new on the horizon?
Yes. The source anticipates the approval of PSMA-directed radionuclide therapy, specifically Lu-177, PSMA-617. This therapy uses a molecule that binds to PSMA, highly expressed on most prostate cancer cells, to deliver targeted radiation directly to the cancer cells. The VISION trial showed a survival benefit for this therapy compared to best supportive care in heavily pretreated mCRPC patients. Approval is expected soon at time of source publication.
With all of these effective options now, AR drugs, chemo, PIRP inhibitors, immunotherapy, radium, PSMA therapy, how do doctors choose which one to use and when? The sequencing must be complex.
It is. A major focus of ongoing research in clinical practice is determining the optimal sequence and potentially combination of these different agents to maximize the benefit for each individual patient. There's a trend towards testing and using many of these agents earlier in the disease course, when the tumor burden might be lower and the cancer potentially less biologically diverse or resistant.
Has the success in treating CRPC in patients living longer led to any new challenges or changes in the disease itself?
Yes, the source notes that one consequence of patients living longer with CRPC due to these improved therapies is an observed increase in the frequency of tumors that undergo what's called lineage transformation, or plasticity.
Lineage transformation? What's that?
This is where the cancer cells change their fundamental characteristics, sometimes losing their typical prostate adenocarcinoma features and taking on characteristics more like neuroendocrine cells, similar to small cell lung cancer. These neuroendocrine differentiated tumors are often highly aggressive and unfortunately resistant to most of the available standard therapies, representing a major unmet need.
Pain management sounds incredibly important throughout CRPC, especially with bone metastases being so common.
It absolutely is a critical part of comprehensive care. Pain from bone metastases is a feared complication and a major cause of morbidity and reduced quality of life. It's important first to distinguish it from non-cancer causes of pain common in older men, like degenerative arthritis, spinal stenosis, or vertebral compression fractures due to osteoporosis, which can be worsened by ADT.
What about urgent situations like nerve compression?
Any neurologic symptoms suggesting compression of nerves at the base of the skull, or more commonly spinal cord compression, require emergency evaluation and treatment. Delay can lead to permanent loss of function. The best treatment for symptomatic cord compression is typically urgent external beam radiation to the affected area, sometimes preceded by steroids or surgery.
How is more general bone pain treated?
Single localized sites of pain can also be effectively treated with external beam radiation. For more diffuse bone pain without neurologic deficits, options include bone-seeking radioisotopes like radium-223, which provides pain relief and prolongs life, or older agents like 153-SM&S EDTMP, approved for pain palliation but not shown to prolong life. Mycoxantrone chemotherapy is also approved for pain palliation but doesn't improve survival. Importantly, many of the systemic therapies we discussed, abiraterone, enzalutamide, docetaxel, cabazitaxel, also provide significant pain relief in addition to prolonging life, and pain palliation was often a key secondary endpoint measured in the trials that led to their survival benefit approvals.
So some drugs treat pain and extend life, others just treat pain?
Correct. That's an important distinction when choosing therapies.
Are there drugs just for protecting the bones themselves from complications in CRPC?
Yes. Bone-targeting agents like intravenous bisphosphonates, specifically zoledronic acid, or the rancolidine inhibitor denosumab, given as a subcutaneous injection, are standard care in CRPC with bone metastases. They have been shown to reduce the frequency and delay the development of skeletal-related events, SREs.
What are SREs?
Things like pathologic fractures, spinal cord compression, the need for radiation or surgery to bone for pain, or impending fracture. These agents help strengthen the bones and reduce these complications. While they help the bones, their direct effect on the cancer growth itself is generally considered modest, and their benefits in reducing SREs are often seen without significant PSA declines or tumor shrinkage on scans.
This CRPC state definitely requires that elite professional level of understanding. It's such a complex and rapidly changing puzzle of understanding the biology, managing symptoms, timing treatments, and choosing the right tool from a rapidly expanding toolbox.
What's fascinating and hopeful here is how our deepening understanding of the cancer's biology, even when it becomes resistant to initial therapies, has directly fueled the development of so many new treatment avenues that are making a real difference for patients.
Okay, we spent a lot of time on cancer, which is clearly critical and complex. But let's shift gears now and make sure we unpack the other side of prostate health, covered in the chapter, the non-cancerous changes that are actually even more common. Benign prostatic hyperplasia, or BPH.
Right. BPH is an extremely common condition in aging men. It refers to the non-cancerous enlargement of the prostate gland, specifically the pathologic process of cell growth. This enlargement is a major contributor to what are known as lower urinary tract symptoms, or LUTS.
LUTS, lower urinary tract symptoms. What exactly are those symptoms?
LUTS encompass a range of symptoms that arise from dysfunction in the lower urinary tract, the bladder, and the prostatocreta area. They are typically subdivided into two main categories: obstructive symptoms and irritative symptoms.
Okay, can you give us some examples of each type? Obstructive first.
Sure. Obstructive symptoms relate to difficulty emptying the bladder because the enlarged prostate is physically blocking and squeezing the urethra, the outflow tube. These include things like difficulty starting the urine stream, hesitancy, needing to strain or push to get the urine out, having a weak or slow urinary stream, the stream perhaps stopping and starting intermittently, leaking urine at the very end of urination, terminal dribbling, having a sensation that the bladder isn't completely empty even after you've finished, and just generally taking a long time to urinate.
Okay, those all sound like blockage issues. What about the irritative symptoms?
Irritative symptoms often relate to changes in how the bladder itself stores urine that reacts to being full, sometimes as a result of working harder against that obstruction over time. These include needing to urinate very frequently during the day, frequency, having a sudden, strong, difficult-to-ignore urge to urinate, urgency, sometimes leading to leaking urine before you can get to the bathroom, urge incontinence, having small voided volumes, and waking up multiple times at night specifically to urinate, nocturia.
So it's not just the physical blockage from the enlarged prostate causing all the problems.
Well, the source notes that while the physical mass effect of the enlarged prostate contributes significantly to LUTS, the symptoms and potential complications are also often linked to age-related changes and dysfunction in the bladder muscle itself, the detrusor muscle. The bladder has to work harder against the obstruction and can become less efficient at storing or emptying urine over time.
How are these symptoms measured and diagnosed? How does a doctor figure out how bad it is?
Doctors typically use standardized and validated questionnaires to objectively assess the severity and impact of LUTS on a patient's quality of life. The most common one used in the U.S. is the American Urological Association Symptom Index, AUASI, which is identical to the International Prostate Symptom Score, IPSS.
What's on that questionnaire?
It asks about the frequency of those specific obstructive and irritative symptoms we just mentioned over the past month, like hesitancy, weak stream, frequency, urgency, nocturia, and scores them. There's also a question about how much the symptoms bother the patient overall, quality of life. Using this index serially over time is very useful for following patients and seeing how they respond to therapy.
Does everyone with BPH or even LUTS need treatment?
No, absolutely not. The source is quite clear. Men with BPH who have no significant symptoms or symptoms that don't bother them do not require treatment, regardless of how large their prostate might be on exam or ultrasound. Treatment is primarily driven by the presence of bothersome symptoms or the development of complications.
What are the complications that would require treatment?
If BPH leads to specific complications like the inability to urinate at all, acute urinary retention, visible blood in the urine, gross hematuria thought to be from the prostate, recurrent urinary tract infections, or the formation of bladder stones due to incomplete emptying, then further evaluation and treatment are definitely necessary.
What other tests might be done for men who do have bothersome symptoms?
In addition to the symptom score and a physical exam, including DRE, a doctor might perform uroflowmetry. That measures the rate of urine flow during urination. A low flow rate supports the idea of obstruction.
Okay.
A bladder ultrasound performed immediately after urinating can measure how much urine is left behind, the post-void residual or PVR. A persistently high PVR might suggest the bladder isn't emptying well and could indicate a need for intervention.
Are there more complex tests?
Yes. For some patients, more complex urodynamic studies might be done. These involve placing catheters to measure pressures inside the bladder and abdomen during filling and voiding. These pressure flow studies can more definitively detect obstruction and also assess the bladder muscle's function, helping to distinguish between problems caused primarily by the prostate versus problems caused by the bladder itself, like detrusor underactivity or overactivity.
When would other tests like cystoscopy be needed?
A cystoscopy, where a small camera is inserted through the urethra to look inside the bladder and at the prostate, is recommended if there's blood in the urine, hematuria, or often done before planning surgical treatment to assess the anatomy of the prostate and bladder neck. Upper tract imaging, like an ultrasound or CT scan of the kidneys and ureters, is generally advised if there's hematuria, a history of kidney or bladder stones, or prior urinary tract problems to rule out issues higher up.
What's the main goal of therapy for BPH symptoms? What are you trying to achieve?
For the vast majority of men seeking treatment for BPH, The primary goal is symptomatic relief, improving those bothersome LUTS to enhance their overall quality of life. Preventing future complications is also a goal, especially for men with more severe symptoms or larger prostates.
What are the main medical treatment options? Pills, basically.
Yes, medical therapies are usually the first line of treatment. They target different aspects of the BPH process. One major class is the alpha-adrenergic receptor antagonists, or alpha blockers, drugs like tamsulosin, alfuzosin, silidose.
How do they work?
These drugs work by relaxing the smooth muscle tissue within the prostate gland and at the bladder neck. This reduces the squeeze or resistance to urine flow, making it easier to urinate. They address the dynamic component of obstruction and usually provide noticeable symptom relief relatively quickly within days or weeks.
Okay, relaxing the muscle. What's the other main class?
The other main class is the 5-adotactase inhibitors, or 5-ARIs, finasteride and dutasteride. We mentioned these in the context of cancer prevention trials earlier.
Right. How do they help BPH?
These drugs work by blocking the conversion of testosterone to the more potent dihydrotestosterone, DHT, within the prostate. Since DHT drives prostate growth, these drugs cause the prostate gland to gradually shrink in size over time. They address the static or fixed component of obstruction related to prostate volume. Their effect on symptoms is slower than alpha blockers, often taking several months, maybe 3-6 months or more, to become noticeable.
Do they have other benefits besides symptom relief?
Yes, a key benefit of 5-ARIs, shown in large trials like MTOPS, is that they can prevent BPH progression over the long term. They've been proven to reduce the risk of developing acute urinary retention, sudden inability to urinate, and reduce the need for BPH-related surgery down the road, particularly in men with larger prostates.
Can those two types of drugs, alpha blockers and 5-ARIs, be used together?
Yes, combination therapy using both an alpha blocker and a 5-ARI is a very common and effective strategy, especially for men with moderate to severe symptoms and evidence of prostate enlargement. The goal is to get the faster symptom relief from the alpha blocker, while also getting the long-term benefits of prostate shrinkage and disease progression prevention from the 5-ARI.
You mentioned ED drugs earlier, the PDE5 inhibitors. Do they really help BPH symptoms too?
Yes, interestingly, phosphodiesterase 5, PDE5 inhibitors, like sildenafil, vardenafil, tadalafil, avanafil, which are primarily used for erectile dysfunction, have also been shown in studies to provide improvement in LUTS secondary to BPH. Tadalafil in particular is approved for daily use for this indication. The exact mechanism isn't fully clear, but likely involves smooth muscle relaxation in the lower urinary tract.
Is there any issue using them with alpha blockers?
The source notes some controversy or caution, particularly with combining short-acting PDE5s, like sildenafil, with certain alpha blockers like tamsulosin, due to the potential for additive blood pressure-lowering effects, hypotension. Often separate dosing times might be recommended.
And what about those irritative symptoms like urgency and frequency? Are there specific drugs for those if they persist?
Those symptoms, as we discussed, can sometimes be caused by an overactive bladder, OAB, which often coexists with BPH-LUTS. Anticholinergic medications like oxybutynin or tolterodine, or newer beta-3 agonists like mirabegron, which are typically used to treat OAB by calming the bladder muscle, have been evaluated and are sometimes used, often cautiously or in combination with other BPH drugs, to help manage persistent irritative LUTS in men with BPH, provided they are emptying their bladder adequately.
If medical therapy isn't enough, or for patients with complications, is surgery the next step for BPH?
Yes, surgical therapy is generally considered second line, typically reserved for men whose symptoms haven't been adequately managed by medical therapy, who can't tolerate medications, or who have developed complications like recurrent retention, bladder stones, or recurrent infections related to BPH.
What's the goal of surgery?
The fundamental goal of BPH surgery is to physically remove or ablate the obstructing prostate tissue, thereby reducing the resistance to urine flow out of the bladder.
What are some of the common surgical procedures mentioned?
The historical gold standard, and still commonly performed, is transurethral resection of the prostate, or TURP. This involves inserting an instrument through the urethra and using an electrical loop to cut away and remove the inner part of the prostate tissue chip by chip. Other approaches include transurethral incision of the prostate, PUIP for smaller glands, open prostatectomy, removing the inner gland through an abdominal incision, for very large prostates, and various minimally invasive techniques using lasers like HOLEP or green light, or other energy sources like rhythm steam therapy or Urolift implants, to remove or reshape the prostate tissue with potentially fewer side effects or faster recovery than TURP. The source also briefly mentions older or less common approaches like TULIP, stents, or hyperthermia.
So BPH isn't cancer, but it's incredibly common, can significantly impact quality of life through those bothersome urinary symptoms, and there's really quite a range of ways to manage it, from different types of medications targeting different aspects of the problem to various surgical procedures if needed.
Absolutely. It highlights that even a benign condition in this area requires careful evaluation, personalized management based on symptoms and anatomy, and ongoing consideration of the patient's overall health and quality of life goals.
Wow, we have unpacked a tremendous amount of information today, really diving deep, guided by this comprehensive source chapter on benign and malignant prostate diseases.
We really have.
We started right at the beginning, understanding just how common prostate changes are as men age, including those really high rates of subtle cancer found at autopsy, and why that fundamental fact forces clinicians to adopt a careful, risk-adapted approach, using that framework of clinical states to guide decisions.
We built on that foundation by exploring the prostate's anatomy, its location down there in the pelvis, its crucial neighbors like the bladder, rectum, and nerves, and how its different zones, the transition and peripheral zones, are prone to BPH and cancer, respectively, all influenced by key hormones like testosterone and DHT.
We then delved into the epidemiology of prostate cancer, grappling with that central paradox, the 1 in 8 diagnosis rate versus the much lower 1 in 41 disease-specific mortality rate.
Right, that gap.
And the complex web of factors influencing risk, from genetics and ethnicity to environment, diet, lifestyle, and even potentially chronic inflammation.
From there, we moved methodically through the diagnostic pathway, discussing the tools for early detection like the DRE and the much-debated PSA test, including its limitations and the guidelines around its use. And we talked about newer second-line tests like 4K score and PHI, designed to refine risk assessment before biopsy. We covered how biopsy confirms the diagnosis and how the critical Gleason grading system, now helpfully simplified into the 5 grade groups, assesses the cancer's aggressiveness based on its microscopic appearance.
And we understood how prostate cancer staging, using the TNM system and various imaging modalities like MRI and bone scans, attempts to define the extent of disease while acknowledging the limitations of current imaging and the vital role of prognostic models and nomograms in giving a more personalized prediction of outcome, especially for those early-stage cancers.
We then spent significant time breaking down the main treatment options for cancer believed to be confined to the prostate radical prostatectomy, the different forms of radiation therapy, external beam like IMRT and brachytherapy, and the increasingly important option of active surveillance for low-risk disease.
Right.
We looked at how the choice between these is made, how outcomes like PSA control and survival are measured, and the specific impacts on quality of life, urinary, bowel, sexual function, as illustrated by trials like Protectiving.
We followed the journey further to understand what a rising PSA after initial treatment might mean, how newer, more sensitive imaging like PSMA PET is changing the assessment of recurrence, and how factors like PSA doubling time help predict risk in that challenging biochemical recurrence state.
And we went deep into the management of metastatic prostate cancer, first in the non-castrate or hormone-sensitive state. We understood ADT as the historical cornerstone, the different ways drugs achieve it, its significant side effects including bone loss and metabolic changes, and the major leap forward brought by combining ADT upfront with newer agents like docetaxel, abiraterone, or next-gen AR antagonists. Finally, we tackled the complex and evolving landscape of castration-resistant prostate cancer, CRPC. We understood that the cancer is growing despite low testosterone. The biological insights into persistent AR signaling and other genetic alterations like DNA repair defects, and the rapidly expanding range of life-prolonging therapies now available targeting AR, PRP inhibitors, immunotherapy, chemotherapy, radium-223, and soon PSMA-targeted radioligands. We also touched on the importance of managing symptoms like bone pain and the emergence of new resistance mechanisms like lineage transformation.
And we rounded out this comprehensive deep dive by switching gears to cover benign prostatic hyperplasia, BPH, detailing its common LUTS, obstructive and irritative symptoms, the tools used to diagnose and assess them like the AUSI score, and medical therapies, alpha blockers, 5-ARIs, PDE5 inhibitors, and surgical approaches like TARR, lasers, etc., used to manage this incredibly common condition that, while not cancerous, significantly impacts quality of life for many men.
You've truly covered the waterfront, moving from the foundational biology and prevalence all the way through the complex treatment landscapes and decision points for both benign and malignant prostate disease, really mirroring the depth of the source chapter.
And by navigating the source material together, You, the listener, have gained a level of understanding that goes far beyond just knowing the names of diseases or treatments. You've hopefully grasped the nuances, the challenges, the risk assessments, the controversies, and the rationale behind these complex clinical decisions. That ability to integrate the anatomy, the statistics, the pathology, the clinical states, and the treatment strategies, that's really what it means to understand this topic at that elite professional level we aimed for.
It's certainly a lot to process, but seeing how all the pieces fit together, from that high autopsy prevalence driving the need for risk-adapted approaches to the biological understanding of resistance fueling new therapies, hopefully makes the complexity more manageable and coherent.
Absolutely. And it leaves us with some powerful questions to consider as this field continues to evolve so rapidly. For instance, given the high prevalence of clinically insignificant, low-risk cancers and the known harms of overtreatment, how will we continue to refine our early detection and diagnostic efforts to become even better at specifically identifying only those cancers that are truly destined to cause harm while safely leaving the others alone?
That's a key one. Or maybe, as we gain even deeper molecular insights into individual tumors through genomics and other omics, how will truly personalized treatment strategies based on specific genetic or biological markers of man's cancer continue to reshape and maybe even replace some of the broader standard approaches we've discussed today, moving beyond just Gleason score and stage?
Definitely something to mull over as you process everything we've covered in this deep dive.